Buenas and half a day, everyone. This virtual meeting of the Senior Citizens Housing Task Force is hereby called to order. For the record, today is Wednesday, April 20th, 2022, and the time now is 10:03 a.m. In accordance with the open government law, notices of this meeting were sent on April 13, 2022, and again on April 18th, 2022. In addition, this hearing was noticed in the Guam Daily Post and the Guam Legislature's website. Before we proceed with the discussions with items on our agenda, I'd like to first provide some general rules of conduct, some reminders for everyone attending via Zoom. We ask that all abide by these rules of conduct and quality assurance standards, and please keep your video on at all times and ensure that you are in a room with little interruption and adequate lighting so that we can see your face. Please remain muted until you are called on to speak. The task force staff will mute all participants until called upon. When called upon, please make sure you are unmuted and speaking into your microphone. If you would wish to speak, please indicate in the in-app feature. In case I don't see you raising your hand, please put it in the chat. And during a vote on a motion, members of the committee shall show a raise of hand to confirm their vote. If there is an objection, please state the objection, unmute yourself and state your objection. And of course, discussion for today's meeting shall be confined to the substance and nature of our agenda, as our agenda has been noticed to the public. Any personal inference as to the character or motive of any member of our task force is not permitted, and any violations of this rule will result in removal from our meeting room. So again, thank you very much, everyone, for joining us for another installment of our virtual meetings of the Senior Citizens Housing Task Force. For those who are watching at home, Public Law 35-140 established the Senior Citizens Housing Task Force with the purpose of assessing senior housing availability and needs. This task force is composed of government officials, community stakeholders, and housing experts, and we will be responsible for developing long-term solutions for Guam's aging population's living needs. Thank you, everyone, and this is our fourth meeting together. We recently met in an unofficial setting with other folks as well during the University of Guam Center for Island Sustainability conference symposium on housing, where we discussed the needs of our elders, some of the gaps in the housing situation for them, and focused on assisted living, healthier lifestyles, community support, federal grants and programs, and local and private healthcare partnership, as well as a large focus on individuals with disabilities during our panel discussion. So I want to thank everyone who was there and who provided all of that information to a bigger audience, and I look forward to continuing that conversation here today. Okay, I also like to thank those who are watching. I know there are some senators who asked to log on with us who are not a part of the task force, but are interested in tracking the work that we're doing, and so they can know what to look forward to when we put out our master plan at the end of this working group. So I'd like to ask now for our staff to take roll call.
Senator Amanda L. Shelton.
Half a day.
Ms. Charlene San Nicolas.
Half a day.
Ms. Edith Pangilinan.
Half a day.
Ms. Elizabeth Napoli.
Buenas.
Mrs. Diana Calvo. Mrs. Lourdes Mendiola. Ms. Melanie Mendiola.
Hi, answer that for Melanie Mendiola, please.
Ms. Phyllis Leon Guerrero. Dr. Margaret Hattori Ujima.
Half a day. Thank you.
All right, thank you very much. I'd like to just state again for the record that we are still awaiting 2 representatives to join us on the council. And that is a representative from the Guam Association of Realtors to be appointed by Governor Leon Guerrero. We have sent a reminder and asked for that appointment, but we will again send another follow-up. And a representative from the Guam Council on Senior Citizens, which I know has not been established just yet or re-impaneled. So we are still waiting for that to happen. All right, we have meeting minutes from our last meeting on March 18th, 2022 that are in our Google Drive folder. So if we can get a motion to ratify our meeting minutes.
Motion to approve?
Yes, thank you very much, Ms. Pangilinan. Is there a second?
I'll second it. Thank you.
Okay, thank you. Moved by Ms. Pangilinan, seconded by Shar. Any objections to ratifying the minutes? Okay, hearing none, motion passes. We are now in old business. So in our last meeting, we discussed identification and assessment of our current resources. So there were updates from GORA and our Division of Senior Citizens. And I know we were awaiting some information on the identification of new resources and infrastructure funding that may be coming to Guam. I know that Mrs. Napoli, you were to meet with the chief planner and perhaps have an update by this time. I'm not sure if it's happened yet, but if you've had that meeting, is there any update that you can give us?
No, I'm really sorry, Senator Shelton, but we've had some urgent matters that we've had to address. So I have not had that meeting with my chief planner as of yet. I will let you know when I do.
Okay, thank you very much. We will table that item for our next meeting or as soon as you have that meeting for us to learn about new infrastructure funding that may be applicable to our Senior Citizens Housing Task Force. All right. And I know also the Division of Senior Citizens discussed receiving formula funding somewhere in the month of April. So if there's any update from Division of Senior Citizens?
No further updates from what we had mentioned was our anticipated funding, grant funding for our core services with our division.
Okay, thank you very much. In the last meeting, we talked about the viability of long-term insurance for our seniors and how they would be able to afford any of these services or living in any of these senior housing facilities. We knew that that would be a challenge, and we wanted to bring in some of our insurance experts to help us better understand what the type of insurance and coverage we could expect. So I want to welcome Ms. Terry Gumatautau here from the Medicaid office, who's with us to discuss some of these issues and answer any questions that we may have on the task force to help guide some of our actions moving forward. Hafiday and welcome.
Hafiday and buenas everyone. Thank you for the invitation, and I guess we'll proceed as you guys have any questions or concern. I can elaborate more on the coverage of the Medicaid program as well as the MIP program.
Okay, sure. Could you give us an overview of the type of coverage that you provide and what seniors are receiving at this time?
Under the Medicaid program, I think what you guys are more looking for is the home health services or home care services. Okay, so, and that one is also applicable to the MIP program, the Medically Indigent program. So both of them do provide these services for elderly and disabled for home health services. There's other services as well. It can include medical services, surgical services, devices, implants, things that's needed to, alter their prognosis or improve their daily lives as well. So do you want me to go down on the type of coverages that you guys need? Because, the health program has a huge and diverse type of services that are covered. I just have to ask you guys specific details. What I can do is I can share with you the benefits and limitations and how each program, because we have the program under Medicaid, but it's for the what they call the childless adult group, 19 to 64. So some of these disabled individual may fall in that category, but if they are total and permanently and totally disabled, they can also go under the regular Medicaid program. It's just distinguishing them on the eligibility is what the challenge would be. So what I can do is, let me share with you, it's a quick, quick sheet that we use for the benefits and limitations that we have for the programs. So would you guys
Sure.
like to see that? Okay.
Yes, sure. Please proceed.
So I'm gonna need to share the screen. Someone can share the screen with me. That way you
Yes.
guys can look at our coverages.
Allow her. Yes.
Pull it up. Hold on. Let's slide into. Okay. You guys can also, because it's also Public Health Awareness Month or week, so we are doing presentations. So we will be showing also the coverages on our presentation, the Zoom presentation of our programs. Do you guys see the screen? What do you guys see?
Not yet. We can't see your screen, but Aisha, if you can please allow her to share the screen.
She
should be allowed.
she's Senator. She should be allowed to share her screen.
Do you see an option to share, Ms. Cherry?
Is this supposed to disable? It disabled me, Madam.
Why is it?
Just make your co-host. It should make her function then. Yeah, try again.
Okay, now I'm able.
Okay, there you
Okay, do you guys see it now? Do you guys see something?
Yes, we do.
Okay. I'm just gonna skip past that because this is our presentation. If you look, there's a link that'll be on our PowerPoint presentation for this afternoon. And you can see, if any of you guys would like, you can, all you have to do is copy this link right here, the website link, and then you can open all our resources for the Medicaid and the MIP program. So what I'm gonna do is I'm gonna show you guys step by step, okay? So we're gonna click into it. And then you guys will see our website of the resources. This is just strictly for the Bureau of Healthcare Financing Administration. And in this area, in this website here under the Bureau of Healthcare Financing Administration, you have all the resources of our state plan, even our demographic reports for the expenditure and the demographic that's if you guys want information on that, and it's quarterly, as well as the all-file and referral packet and application for the Medicaid and the MIP program. If just be mindful on the Medicaid and MIP application, it's handled by the Bureau of Economic Security. Okay, it's another bureau. And the application itself is not only Medicaid and MIP, it's also for SNAP and the cash programs. Okay, So that's the application there. And then you're also gonna see further down what they call Medicaid, ABP, and MIP benefit limitation. I'm gonna click into it so you guys can see, okay? So now we're in it. Okay, as you can see, you guys may wonder, what is ABP? It's a program, a sub-program under Medicaid for the childless adult group that Obama implemented a couple of years ago. It's for individuals that don't normally qualify for Medicaid, and those are adults 19 to 64. And the coverage that they're supposed to get under the Medicaid program is called Alternative Benefit Plan. So that's why you see two columns here, okay? This is the regular Medicaid benefit plan coverage. This is for the childless adult group, the 19 to 64, they're under Medicaid, and they're called MAPNE, the childless adult group. And this is the MIP, okay? We just, as we go down, as you can see, abortion, acupuncture, acute inpatient care services, allergy and testing, ambulance and medical transport, ambulatory surgical center. Ambulatory surgical center is what they call ASC, is where they can do surgeries. There's one surgery center and half a day, okay, that can do surgery outside of the hospital. And they have audiological examination, birthing center, blood and blood products, breast reconstructive surgery, and then you have cardiac. You're wondering why this is highlighted? It's because these are the expanded services that just got approved by CMS to cover the additional like devices. Now we're covering AICDs and other devices that are very costly for any cardiac situation, okay? So as you can see, previously it was only pacemaker, heart valve, and stent. Now we are covering the AICD, the defibrillators, and other devices that are for cardiac, okay? And then if you go down, there's cataract surgery, chemical dependency, chemotherapy, chiropractic, circumcision, congenital anomaly disease coverages, elective surgery, emergency care, emergency room services, end-stage renal disease, that's the dialysis, eyeglasses, and we just increased our eyeglasses for the frame and the lenses to now 150 for corrective and 200 for the bifocal. It used to be $85 for the corrective and 128 for the bifocal, okay? Then we have the eye refraction, we have dental services, diagnostic testing, and this is the DME. These are the equipments that can be covered if a disabled individual or an elderly that needs medical equipment at home or to travel around, okay? Because as you can see, there's CPAP and BiPAP machine. So some people are oxygen. So some of the patient may need these. So these are the services that are under durable medical equipment. We also cover medical supplies that's needed, especially if they wound care and even under dialysis, because some of the dialysis, they need gauze and things like that. So those are also covered. So they fall under this category, okay? Then you also have fitness. This one is for gym membership. It's only for the ABP, okay? Not for Medicaid, not for the regular Medicaid, and not for the MIP. This is only for the 19 to 64, okay? Hearing aid, then here's the home health services, which is everybody is probably talking about to help the disabled. Okay, under the home health services, as you can see, we cover nursing services, home health aid services, and that one is relating to personal care. Okay, but it's very limited. It's limited only for medically necessary services. Okay, now we go under hospice, immunization and vaccination, inhalation therapy, laboratory, maternity care. These are other practitioners that we do cover. Okay. Then we have mental health services, nuclear medicine. Then we have occupational therapy. This one we just started covering now again. It was effective, like I said, October 20, 2021. Or let me double check, because I know we expanded, because the services, there's a lot of services, but I know we just extended these services just recently. That's the reason why it's highlighted. Physical therapy used to be only allowed, and occupational therapy was only allowed before at the hospital setting, only at GMH and GRMC. Now it's been expanded to be provided now in a non-facility setting at the clinic, home health services agency, or at home. Okay, that's for the occupational. This one's occupational, and physical therapy is down below. Okay, we also cover off-island medical care, which is the off-island referral. There's a link that I just showed. Okay, you can submit the off-island referral packet, but it's has to be completed by a referring physician. Okay. This one, there's the orthopedic. We also expanded the orthopedic. Okay. And then we go to pharmaceutical. That's just prescription medications. And now we go on to physical examination. That's just annual physical for everybody. And physical therapy, like I said, we expanded it instead of just inpatient. That used to be just inpatient and outpatient, like I said, at GRMC or GMH. Now they can provide those services in a non-facility, home health service agency, clinics, or at home. Okay, physician care, prenatal care, prosthetic devices. These are also devices that are needed. It's not only for cardiac, but just other related medical conditions. Okay, so we did expand now to cover those devices: radiology, radiation therapy, SNF, skilled nursing facilities, sleep apnea, tobacco cessation treatment, voluntary sterilization, EPSDT, which is well child care, wellness. That's it. Okay, if you see on the bottom right-hand side, you see these are the other programs that Medicaid MIP does cover. We cover also lithocobotic, which is a special medical condition, in diabetes, which we only provide independent diabetes. These are for the ones, these that you're seeing on the bottom right-hand side, the 92 cases, 93, 94, and 95, 97, and 99. There are these are more of medical condition, except for the 95. These are medical condition individuals because they have exceeded the income table of in other words, they're not eligible for the MIP or the Medicaid program, but this one helps them in some of their medical expense. That's why it's only specifically to the 5. Lithocobotic, insulin, which is diabetes, tuberculosis, end-stage renal, and leprosy. It's up to 1,000 above the income table. Okay. As you can see, there's a 95 case, which is called Medicaid Supplemental. These are for individuals that are under the Medicaid program, and Medicaid does not cover intermediate care facility services, which is what St. Dominic's is offering. Okay, so if they're under Medicaid, we give them a supplemental MIP MS to cover the St. Dominic's. That's why you see a 95 case. Like I said, it's intermediate care facility services. That is not covered under Medicaid. So of course, these patients really need these services, but only MIP. So that's why we cover them under the MIP MS. So they're gonna have dual coverages. So any question now regarding, the coverages? And I can elaborate more when you guys have any questions.
Thank you very much, Ms. Gumtao. We have a question from Dr. Hattori.
Okay.
Thanks so much. This was great. And I had 2 questions. So on the supplements down there, are those all designated by public health, or is that something that needed legislation? Just out of curiosity.
Sorry, I was on mute. Which, can you repeat the question? Is it because
Oh, yeah.
you talked about the MIP?
Yeah, you know, the 92 through 99, those supplements,
Mhm.
were those, is that something that public health thought of? I mean, those are great. Like, I totally agree with the things that you're covering. Is that something that public health can decide, or is that something that you need legislation on to set up these supplementals?
It's the public law 27-30.
Okay.
It's specific to those. So
Oh, okay.
I was kind of thinking, you know, because I know everyone, I guess, wants personal care, especially for the disabled. And I kind of just realized something, because under the Medicaid program, we do, like I said, if I go back up, okay, I'm going to go back up to the home care, okay, the home health services. The reason why I'm going up to the home health services is because I wanted to show you guys, because I think some of you guys were asking questions regarding, you know, the disabled to have some personal care services. Under the home health services, as you can see, we have what they call the home health aid services. Those can provide personal care services, but it's very limited to those that are medically, you know, necessary at home, okay? But they can also provide, like I said, the personal care services on bathing, eating, feeding, you know, and all that. But the time is very limited, okay? So what it is that, and the problem we also have is, even if we do cover it, we're very limited with resources. We only have 2 vendors on island, 3 actually now, 3. FHP is one of them, and Home Health Services of the Pacific is the other, and the Guam visiting nurse. They can provide these services. The problem they have is, I think, I'm not too sure, because I think Guam visiting nurse might be closing, I guess, with all this COVID. So I haven't gotten a full notification that they're closing. So that leaves us down with 2 vendors. So, and even if we do, you know, we do provide the services, the challenge we have is having these providers to have these individuals or staff or personnel to provide the service. So just looking at it, I know everybody keeps, you know, bringing up something about, like, I guess, assisted living and the personal care services. I just kind of thought of something, because in the Medicaid side, it has that, and it's for the home health aid. At the same time, it's for the medically necessary services. So if anything out of that, I was thinking, you just have to be careful, because MIP, I was thinking of doing, if you go all the way down, remember what Mr. Torre was asking? If you look, Mr. Torre, see the 95 here? Can you see the 95?
Yes, the Medicaid Supplemental, right.
It's called Medicaid Supplemental. What it is that we can probably expand some of those services, but we cover them under the MIPMS, especially if it's not medically necessary or anything that's not within the parameter of the Medicaid coverage. So we can put it here. The problem,
and Ms. Terry, sorry. So I put in the chat a couple links, but that's a great idea if it's possible. But you're right; they may not necessarily would not meet the certified home health requirements, right? If they're not medically necessary, right? But Medicaid in other states has that, and I know it's I think it's Mrs. Lourdes Mendiola that brought it up at one of the meetings, that in many states Medicaid will pay. You can pay a family member to be a caregiver. Like, I worked in California in a certified home care agency, and in California, family members could be paid to take care of their loved one, which, you know, I'm pretty sure it was Ms. Lourdes that mentioned, you know, families are quitting work, staying home to care for their loved ones, disabled or, you know, elderly as well. But I don't know how Guam could get that coverage if it's an expansion of Medicaid benefits, or if, like you're saying, is that something that could be a supplement? So I'm thinking of that separate from what you're saying, because you're right, those people won't qualify for Medicare, Medicaid, the CMS definition of certified home health, right? That's a separate coverage, but it's this, and I put it in the chat because in this spot, they're calling it cash, and they have a name for it, which I never heard. Cash and counseling programs getting paid as a family caregiver. And even the AARP website as well spoke about the Medicaid coverage for that. And Ms. Terry, thank you, because you really know Medicaid, and I just don't know Medicaid at all. Like, is that something that's possible to expand? Would that be a new benefit? And how do you get that expanded versus, like, is that something that could be a supplemental?
It's very challenging, to expand services, because like I said, when I showed you guys previously the highlighted areas that we expanded, we were only able to expand because of the additional funding we got, as well as the increase of the FMAP, but those are only temporary. And right now, even the increase of the funding, it's only for 5 years. And as for the increase of FMAP, from the normal 55% to the currently right now at 83 up to 89 right now because of the PHE, it's only up to the end of this year. So once that the FMAP decreases back to its normal, it's going to be 55. And sometimes it's very challenging to find the local share to match the grant or the funding that we get. So that's one of those issues that we do have. And then at the same time, before all of these additional funding came in, ACA also helped us. The Affordable Care Act, it's already just ended. I think just already now in its 10th year, so it just ended. And when it ended, COVID came in, PHE came in. So those additional funding really helped the program. But if you go back to history, to when we had the CAP funding, we were always on a shortfall, on a deficit. Not only that, we have to carry our expenditure to the next fiscal year. And that's where we end up hurting, because the providers don't want to take us anymore because the payment is delayed. A lot of them don't want to be a provider. We have a good oral surgeon here in Island, but he still refuses to accept us because of the untimely payment history. And I guess he knows the challenge of, he hears it and all that from Medicaid. That's why we gradually just started expanding services, especially the cardiac. Those are individuals that need heart surgery, and guess what? The device is not covered. And some of them cannot even afford it, because some of those devices are $80,000. And then at the same time, I just found out that we cannot even cover the procedure. We were covering the procedure, but not the device. So now that we expanded the service because of the additional funding, now we're able to, we can cover those devices and help these individuals. That's just only on the cardiac. I haven't gone into the other services. So I'm just and like I said, we do have funding. Our funding has increased now to 133 million from the norm of the 19 million that we normally get. So, but that's only temporary. That's only a couple more years. And then at the same time, like I said, the FMAP, it used to be 55. Now it just temporarily increased to 83. And then right now, currently, it's to 89 because of the PHE. And that one's ending December 13th, 2022. We're going back to the 55. So we really do want to expand some services, but we're doing it slowly. And that's why it's always with the word medically necessary. Because if it's not medically necessary, then we don't want to open too much doors to getting us into financial, because if we cannot pay the provider, we don't want to lose the provider. Right now, even off island, Hawaii refuses to accept us. They refuse to sign an agreement because of the history too. So where does a patient have to go? They have to fly all the way to California, San Diego, and Los Angeles. We also expanded our service to include the Philippines, but it was a challenge to get Medicaid covered outside of the US, because that's one of the federal regulations where US money cannot go outside of the US. So, but we were able to justify our program because we're so close to the Philippines, and Philippines can help us save some money, especially on those services. Okay, but it's also a challenge because they're international and they need passports and all that stuff, and they have their own requirements. But see, the good thing is that we're able to go to the Philippines, but it's only one provider that's currently right now accepting, because the requirements of the federal is what's needed to be a participating program under the Medicaid program.
I have a question, Ms. Terry.
Mhm.
Going back on the home health aid services part of Medicaid that includes like the personal care, and you were mentioning that there are only 3 service providers. It was Health Services of the Pacific, one visiting nurses, and there was one more. I missed it.
FHP.
Oh, an FHP. Now, if there is a private business that provides personal care, can a client get approval for that service with the private business, or it's only limited to these vendors?
They can submit an application. The only challenge they're going to have is that it'll be also advisable to see if they can be Medicare certified. The reason why is because a lot of our patients that are elderly or disabled, we purchased the Part B, the Medicare Part B buy-in. Okay, so we kind of assist them in some of the services that is covered under Medicare. So we purchase what is normally, because if they're under the Medicaid program and they are with disability, like they're under dialysis or they're elderly, we can purchase the Medicare Part B for them and we pay for the premium. So that means the Medicare will be the primary and we're the secondary. So we do try to advise, participating providers that want to take Medicaid if they can be Medicare certified, only because that way, if the patient has dual or tertiary insurance, they can charge the Medicare, then they can charge their private insurance, and then they can charge Medicaid less. But yes, it doesn't stop them from, they don't have to be Medicare certified to be a participant of the Medicaid and the Medicaid program. The providers, all they have to do is reach out to us. We'll provide them the application and the required documentation as well. And then upon that, upon submission of all the complete documentation, we brought it for the director for approval.
Thank you for that.
Thank you. I think we also have a question from Mrs. Calvo.
Hi, Ms. Calvo. Hi, Dan.
Hi, good morning. I'm not sure if it was how it was introduced, but I wanted to just bring up that MIP was established to mirror Medicaid for those individuals that did not meet the criteria for Medicaid program, which in the past had to do with eligibility of citizenship, as well as if people were eligible or not eligible for what was the previous AFDC program. And in the MIP program, it also added what we initially referred to as the free care programs, which are those 92 to 95, 96. What I just want to bring up is that what Terry has indicated is, it's the availability also of local monies. So on the Medicaid side, when I was at Public Health, sometimes when there's an increase in the Medicaid funding, we have to match the monies, and there is also a maintenance of effort requirement. And so when there are periods where collections, revenue collections are low and all that, the process involves sometimes not being able to release federal monies unless the local match is there. And so when you have a big increase like what we've had over the past several years, in order to maximize Medicaid funding, that's a lot of local dollars that have to be put into that match obligation. On the MIP side, over the years, there have been some issues with the legislature in terms of the MIP outlays, because the truth of the matter is that on Guam, we have a lot of unhealthy individuals who also are young and become unemployed at a time when they are not, they haven't met their quotas for Social Security, so they don't qualify. So a lot of these individuals end up being eligible under MIP, and then when they turn 65, or if they have some other condition that's a little bit more permanent, they may be eligible for Medicaid. It still adds dollars, and Terry, correct me if I'm wrong, the biggest challenge with the medical programs, both Medicaid and MIP, is that because we pay so many bills, there's usually not enough monies left over to look at what are some of the waiver requirements for Medicaid. Because there are a lot of waiver programs in the states, welfare to work or unemployment of those that are, employment for those that are disabled using Medicaid monies. There's different strategies that jurisdictions have that they can implement using the waiver process. The big difference, though, with Guam particularly is if we already don't have enough money to pay for all of the medical expenses for the whole fiscal year, and we're always carrying forward, bills into the new fiscal year, then it's a big item of consideration when there are other services that are looking to be added that's going to be subsidized by the local monies. And that's always been the challenge. And so, and then when you look at what the government is also subsidizing through the Division of Senior Citizens, Title III services, you'll also see that there's a big overmatch. That I think if we were to just fund local monies to the federal monies, then it's not going to provide the level of services that's being provided today. And so those programs are pretty much overmatched, which means the government of Guam is the one subsidizing a lot of the costs. And we've had that same experience also that, depending on the amount of allocation of local dollars to the programs or to the departments, and then how they further allocate it, it becomes challenging to even sustain the maintenance of effort. That we're going to stay at this number quota, from previous years just because the money is not really there. And and I don't know whether it's what it is, but sometimes it's in the past there used to be, make sure that if you have a contract, it's certified for the whole year. In the past couple of years, and I don't know if it's a COVID thing, we may have a contract, but the certification of monies would only be 2 months, 3 months, or on a monthly basis. So it makes it also hard as a service provider to know if there's going to be, what's going to be the contractual agreement between the government of Guam and the business entity. So there's other things also. I think it's been a struggle to try and see how to increase either the salaries or to ensure that people remain healthy enough in order to be able to work to earn the coverages. But providing the service is one part of it, but being able to pay for it is also another part of the consideration. So that's my add to that.
Thank you very much. Does anyone have questions or comments for Ms. Terry? Okay. You still have more of your presentation?
I have a question,
Okay. Yes, Ms. Liu.
Adam. Just to augment Ms. Diana and Ms. Margaret Hattori, I do agree in the Medicare, and especially for the caregivers. I am encouraging and see how possible that Medicaid can expand to meet that critical need. A lot of families are affected, and I don't know how we can fit that into the MAPNet, into Medicaid, because we can have personal care attendants under some of these professional services, and even though they're limited, however, if the family have that choice of choosing even their family members, it would be a great help, and it's part of healing, because healing is when you're feeling comfortable of whoever gives the care to you. And a lot of these seniors, especially in their dementia mode, it's very difficult for them to express their needs. So it's the families that really know their family. And I just, coming from a family, I just believe that the caregiving is very important in this expansion of Medicaid if we can. Families have been affected by the loss of income because they need to care for the senior citizens and their loved ones too. I mean, including individuals with disabilities. And of course, we need the housing, but this is just part of it, It's really, it's an identified need. I don't know how else to express it. And I know I always, we hear limited funding, but please, policymakers and, the administrators and the people at stake there, if they can, they give us the money. Region 9 gives us the money, or whoever gives us the money. And then it's the state, which is Guam, what will decide how and then distribute it to public health, because they're the ones in jurisdiction for the Medicaid. Then they can determine where the money goes. And if that's a critically needed area, and that can also be expanded for the training of the caregivers. And that's where Ms. Margaret's area, they can expand the trainings to the families. And I know a lot of families need training because they still don't understand that the individual needs of the dementia. It's sometimes confusing for them, and it creates frustration. That's my input in the MAPNet.
Thank you very much, Ms. Liu. Ms. Shar, you have a question, comment?
Yes, maybe Terry, if possible. I know Mrs. Calvo had talked about, some of the challenges with federal funding and the match required to go with any increases and also looking at existing payments. But I think for this group and this task force, if you can share with us and maybe join, if I may, to help us and assist us in going back to Ms. Manjola's request to look at other areas in which Medicaid waivers can be explored. For now, I think looking at the exploration to help the caregivers, because I understand that some of the current common needs are for our disabled and our elderly to be able to hire supervised workers. And I believe that one state I do know in the US, because we've actually been in engagement with them, they do have the Medicaid waivers. And I think it's important for us to explore that on the Medicaid waiver process, so we can be informed on that. To also include the out-of-home respite and expansion of in-home services. If there are only 2 vendors, then maybe reaching out to see how other potential businesses that are out there to be engaged, whether or not they're going to go through the Medicaid process or not. But I think exploration on the Medicaid waiver for this is very important at this time. I know that you had mentioned earlier that we went from the core grants of 19 million up to 133 million. So yes, we can see, and of course, it depends on the federal match requirements, right? If it's going to be at 55 or if it's at 80% on the federal side. But I hope that that is something you can bring back to this task force, because it is something I think that we all would like to get more information on, to include how long is the process? Is it 1 week? Is it 1 month? Who's going to be engaged if a Medicaid state plan amendment is to be made? You know, will stakeholders be part of this? Will there be a public hearing so we can get the stakeholders that are here and those in, you know, different positions to also provide information as to why it's needed. So that's my input. I know that that's a lot. I understand everybody's resources are extremely limited in terms of personnel, but if you are able to, I think that's something that this committee, this task force would appreciate.
Okay, I think there's another question from Mrs. Calvo.
And it's just a question to Terry on, you know, on the middle column of when you were presenting the benefits and comparison of the benefits within the three categories. On that APB, is that only the eligibility for that tied in only to the COVID monies, or is that kind of like another eligibility added?
It's tied in with the what they call the MAP NEG, new eligibility group, the childless adult group that Obama wanted us to implement. So it's those, it is under Medicaid, but they're called childless adult group, 19 to 64. It's a new program category for Medicaid. And on those groups, the mandatory coverage is called alternative benefit plan. That plan is only strictly for the childless adult group. And it's following the federal regulation of the coverages that they want us to cover for that group.
So if
But
the
it is-
COVID money,
It's an addition.
if the COVID money and the CARES monies go away, that category will still stay covered under Medicaid?
It's Medicaid will be carrying the burden of this group as well as the expenditure.
Okay, thank you.
And, oh, go ahead, Ms. Ms.
Ve-
Mendoza.
ver- Yes, very quickly, Ms. Terry, since we are in Medicare, I know housing is a subject, but I think
Medicaid.
since you're there, Medicare,
Medicaid, not Medicare.
I'm sorry, I stand corrected, Medicaid. I'm very concerned about the dental coverage not being covered. And especially the senior citizens and the individuals with disabilities are more prone and more at risk of developing other ailments because of the lack of dental services. You can develop infection in your other areas of your body if you have an infection in your mouth, in your teeth, and it goes down into your body and it lands on your foot, like me. But that's just very, you know, and that brings a concern. Why does Medicaid not cover dental insurance, especially I fall under that ABP, and for other community members, you know, ABP, why does it only have coverage for the people or the family that are childbearing? I don't know how to make sense of that, but can you please elaborate on that? That's a very needed service, dental.
The 19 to 64, like I said, those are the childless adult group. They're normally not eligible for Medicaid. Okay. What happened with that program is the reason why it was created because of Obamacare, the Affordable Care Act. They wanted to expand Medicaid. So of course, Medicaid is normally covered only for families, elderlies, which is families are just children with parent and the children itself, of course, and up to the age of 18. The elderlies, which is 65 and above, the disabled, which is AB, APTD. Okay, those are the two. So if you're disabled, you're elderly, or you're with family with children, those are the regular Medicaid population. This one got expanded because of the Affordable Care Act and expanded Medicaid. They said expand Medicaid to these groups because these are childless adult group that don't fall in any of those population or those groups. Give them coverage under Medicaid under one condition, that you have to follow this benefit plan. And those are the benefit plan that they wanted us to enforce. It's not something that, because they should not be under Medicaid to begin with, but yet we're going to put them under Medicaid. So that's why dental and eyeglasses, I know, is one of the critical health services that I would say is needed for the 19 to 64. But these are supposed to be healthy individuals 19 to 64, okay? So I didn't make the health insurance benefit for the ABP. It was what's regulated. But there is another option under the MABNET group. If you have a slight disability, with the daily living, you can complete the form called medically frail. Those are the only ones, those are the ones that are under the childless adult group, and they have the alternative benefit plan. And they have some disabilities, minor disability, I call it, because they're called medically frail. And they need help in the daily living activities. You complete that form, you give it to a physician, have them complete the form and check mark that you are medically frail, and then you can move from the alternative benefit plan to the Medicaid benefit plan. Then you can get dental and eyeglasses covered. If not, and you are with a disability, you should be under Medicaid disability. So you would automatically get the Medicaid benefit plan. But if you are under, like I said, the 19 to 64 childless adult program, and you have minor disability, have your doctor complete the medically frail form so you can be moved from the alternative benefit plan to the Medicaid benefit plan. And that's where you can get your eyeglasses and dental coverages.
Okay, thank you very much, Ms. Terry. Do you have more to your presentation? Or I'm sorry, I see more hands on the screen. So Dr. Hattori.
Sorry, Senator. I just wanted to add that it's good that she mentioned there's only a few home care agencies that are eligible for coverage. And I know, the suggestion was to expand to some of the private personal care agencies. But I just wanted to caution, and maybe Ms. Gumatauta will know, I know in some states you can run what they're calling a personal care agency, where they, and there are a few on Guam, very small. I mean, my own mom, we hire a caregiver through them. But I also think that, I don't know that they're regulated by public health. I don't know if, in some states they're totally not regulated. And in other states, they are regulated, like Nevada, you have to actually be inspected. Their public health has oversight. So my only caution would be that the agencies she mentioned, like Guam Nursing Service, I know even HSP, and then FHP, and then even when Mrs. Calvo, when CSS was running the IHSS, those agencies have like very strict hiring practices, orientation practices, and the like HSP and Take Care have external agencies like monitoring them, right? But my only caution would be is if we start opening up coverage to the smaller agencies that are not being monitored by anybody, that maybe that's something we should look at to ensure, because right now only the agencies like CSS and Mayor's Council are requiring, some agencies are not requiring that their caregivers are trained. Like they're hiring people that don't have an actual caregiver certification training, whereas Mrs. Calvo requires that, Guam Behavioral requires it. But anyway, so my only caution is if it's not required, we just need to be careful, because I would hate to see any of our disabled or elderly abused in those situations. And in California, we saw a lot of elder abuse by people that were hired off the street saying they were caregivers and they were untrained. So while we have the opportunity to, prevent that, I think now would be a good time to bring it up. But I apologize, I don't know if public health is overseeing those type of agencies.
I'm just glad you brought that up, Ms. Hattori. The reason why I'm glad you brought that up is because we did reach out to try to get the family certified caregiver. That's what we were told, is we want to, like you said, to prevent the abuse. So we are already working with our federal officer to see how we can apply the family caregiver under the program. The problem we did have is that they did say something about getting them certified to prevent, like I said, the abuse. So we don't know. So that's what we were checking on, to see if there's any agency or educational institution that would provide some certification. So that way, once they're certified, we can try to have them covered under the Medicaid program. So that's what we are already currently working on, is to try to see, because we did ask them about coverage on the family caregiver.
Great. Terry,
But
please
they
email
want
me,
to be
because we do have a curriculum. Actually, it was because Mrs. Calvo asked us to develop it, but we've been doing caregiver training for 2 years, and it's I would like to say it's actually a very comprehensive one. But we'd be happy to meet with you if you want us to add particular topics for these home caregivers, but we'll fully support you. Thank you so much. Thanks.
Would you be able to provide me your information, email me, so I can communicate with you, and that way I can also inform our federal officer, that we do have an agency or a company or an educational facility that can provide certification. Because that was one of the concerns they did bring up, is because making sure that these individuals are trained and certified to provide these services, because these are the ones, mostly they're elderly and disabled. Those are the ones that really need protection, and ensuring that we provide them the quality care that's needed. So that was brought up during so I'm glad we all discussed this. So now we can probably all get together, and hopefully we can finalize and submit something for the family certified caregiver coverage.
Thank you. I'll email you. Thanks.
And I think Mrs. Calvo, you have another question?
Yes, and this is for Terry. I just wanted to clarify for HSP and FHP, for those patients that are referred for home health services. Does that include full day caregiving, like they're there the whole day with the patient, or do they come there for certain to provide certain assistance with ADLs on top of, like medication management and IV treatment and stuff like that?
Currently, right now, there's no personal care. They're more of, like I said, it's more of the home infusion therapy. They're more for IV infusion, or like you said, medication management, and they're only there for a couple of hours. Their visit are based on per visit by the hour, how many hours of the IV infusions.
So right now, Medicaid is not, even for Medicare eligibles, there's not a benefit provided that will pay for a full day caregiver.
No, even Medicare doesn't. That's why we were asking, we were reaching out to the 3 our 3 home health agency providers to see what do they charge and what code do they use for personal care, especially only for the home health aid personnel. And according to them, none of them have been charging any private insurance, not even Medicare. So now we have to find a way to find what fee schedule to use to cover these services and the codes, the appropriate codes to use for these services. So we are gathering that and assessing to see which code would be applicable. But we also have to be able to work with the home health agencies to find out if these codes would be appropriate for the services that they'll be providing.
What I'd like to also just bring up as an item of consideration is that there is a specific purpose for the home health care, which CSS and HSP and even FHP that provides, which are, in addition to the medically related functions for medication administration, does include limited assistance for personal care and homemaker chore services. But those kinds of services are not 8 hours. They're normally at minimum 1 hour. And I think that while there's a need for that in order to ensure that elderly and persons with disabilities are able to live in their home, in a clean home, I think the other need is really full-time caregiving is what may be a need. And part of the reality that's attached to that is that people cannot afford to pay for a full-time caregiver. And even if family members were to pool their monies in order to hire a caregiver, it is an expensive route. And so if we're looking at housing, and the cheapest housing really is getting people to stay in their home and we bring supports, but one of the areas where it will be a high cost item is full-time caregiving. And it's a different pricing. It's not a different pricing, but the price changes when you are there like for the day, like daycare, even in-home daycare. If we're going to compare with children, there's variations of how daycare is provided. In-home care, where people come to your house and they take care of your child, those generally may be the cheapest type of daycare service compared to center-based care. But if we're also looking at the need, there's a graduation, because then when you have a family member with dementia, then the caregiving is a little bit more challenging. And if you have, like in my own personal family, we had mom and dad who were both dementia. And, we had some family, they had 10 kids, and the kids pooled their monies to do 24-hour care in their home. And that money was spent in 2 months. And so they had to come again and figure out how to provide the supervised care so that, they're not left unsupervised, one, but it also allows some assistance to the family members who are available to help take care of them physically. So I think we just need to also consider that, the home health services are services that can be brought into the home, but that is different from caregiving, which I think when there's a high need, when people talk about assisted living, part of it is also caregiving. And I think that's probably the bigger cost, which right now is not really subsidized except I think by VA. And even at that, and it would be a similar condition, most of the the VA, they would have that, but you have to go to the states more often in order to avail of that benefit. But I don't think that there's any federal program that provides money for caregiving. So I'm just bringing that up.
Thank you very much, Mrs. Calvo. Any other questions or comments while we're with Miss Terry? Okay, thank you very much, Miss Terry. I know that there were lots of questions and some requests of you. If you're able to perhaps join us in our next task force meeting to provide those updates, we would really appreciate your time once again. And I'd like to thank you for being with us today. Did you have any maybe closing remarks or anything else you'd like to share?
I just thank Miss Diana Calvo for coming in and chiming in. She used to be our chief. She knows the program. So yes, her information, she has a lot, wealth of information. So what she did, that's why I didn't have to repeat myself, because she already covered it and she does understand. But we are mindful. We are trying our best, like I said, to provide as much services for what the community need. But like I said, we also have to be cautious. So, like Ms. Diana said, is that, we got to make sure we have the local share to match it, as well as the full funding to pay for these services. So I agree, and I understand that, with all-day caregivers and personal care, but we do pay St. Dominic's, and just to share with you, we pay St. Dominic's under the MIPMS, and guess what? It's $195 a day. Imagine that. And they take care of these individuals 24/7. And they're only getting paid $195 a day. Okay. So it is, one of it is, like I said, that's why we have the MIP supplemental, because these are individuals that really need the care and attention. So they're in St. Dominic's, but a lot of us don't want to put our loved ones into an intermediate care facility or learn-to care facility. You want them home. So I guess we still all have to get together and try to figure out how can we expand probably the caregiver service, so it can be an all day, and also to relieve the family members, give them some time to do some things, and and the challenges they have on their day-to-day life, because they do have their own family, but they also have to take care of a loved one, and then the financial burden that it applies to them. So that's the only thing I have to say right now. If you guys have any further question, you can just email me. And thank you again, Ms. Calvo, for clarifying and providing more information. Thank you, everyone.
Yes, thank you so much, Ms. Terry. And of course, thank you, Mrs. Calvo, for providing all of your expertise as well. We're really happy to have you on the task force, and appreciate the time from Ms. Terry and the team for today. I want to recognize Senator Tony Atta, who's joined us for the task force meeting. Thank you, Senator Atta, for tuning in with us. Now we'll move on to the next item on the agenda, and we will be sure to invite Ms. Terry back. So if we have any more questions, or she can give us an update on some of those things we asked for. The next item on our agenda is to approve and ratify the goals of the task force. This is something we've been discussing and adding to the last several weeks. And I know that this is something that everyone has had a chance to review. If there's any kind of addition that you'd like to make, please let us know now. I'll read them out for the public so they know what we are going to be voting on. And these are the goals: providing housing for our Manamku within stable communities through the maintenance, renovation, and modification of existing homes, producing new housing that meets the needs of our Manamku while not detracting from existing neighborhoods, providing affordable and diverse housing to meet the needs of low and moderate income senior citizens, providing housing appropriate to accommodate individuals with disabilities, the elderly, as well as healthy aging individuals for physical and mobility needs, providing the appropriate workforce development to ensure healthy and quality aging, and to establish health and safety requirement guidelines for our Manamku living in these housing facilities. So as you know, at the end of this task force, we're going to give these recommendations to both policy recommendations to both the legislature and the governor, the administration, for us to act together on, move legislation here in our body, as well as have the support from the administration. So these are the goals that we've come up with together over the last couple of meetings. And so I'll ask for a motion. If there's anyone who'd like to discuss, I'll ask for a motion to approve these goals.
Can I ask a question though?
Mhm.
All of that is providing the housing, et cetera, right? But can we add in there somewhere about seeking the funding sources for all those provisions that we're going to be working on?
Yes, sure. Okay, that is another point. Okay. Okay, is there any other addition anyone has? Okay, so I've added that point for us to seek funding sources for these projects as well. We can still leave it open if anyone else wants to review or think of an additional goal that we want to add in the next meeting. I mean, this can be a working document. We don't necessarily need to ratify it, but I like for us to have something solid to work on together. All right. Okay, and now, yes, Mrs. Cabo.
Well, I was going to make a motion that we could ratify what we've identified as goals.
Mm-hmm.
And the goals are basically, where we would like to see ourselves in the future. And that, as you mentioned, the understanding would be that these would be fluid, both vertically in terms of either adding in or refining the specific goal itself, and then horizontally, where as we break down certain goals into resources and action plans and all that there could also be certain working discussions related to each certain portions, especially as it involves funding, because one, we would like to make, well, at least for me, I would like to make sure that what we present is also not going to end up being an unfunded mandate where we're not able to deliver on some or most of it because the money is not there. And two, that the goals are also realistic. At least I think that the goals are realistic because we're looking at the primary objective of making sure that every individual is housed. And the focus of this task force is on elderly persons and ensuring that they are all housed in some form or fashion. And so I was going to, and that was part of my discussion, but I was going to make the motion to adopt the task force goals as written to date, and recognize that this would be a fluid process, especially if there are other innovations and research that we do that identifies potential resources.
All right, absolutely. Okay, so there's been a motion to ratify the goals as written today and to allow them to be fluid and guide our work as we continue to meet. And I think that if we do this today, we can take the next meeting to maybe break up into subgroups and set the goals for, or set the parameters for each goal, and for us to work together as a next agenda item in our upcoming meeting. So is there a second to the motion?
I'll
This
second
is
that.
Lourdes.
Okay.
Sorry, go ahead.
Okay.
Okay, thank you very
That's
much.
fine.
Shar. Thank you, Ms. Okay, so moved by Mrs. Calvo, seconded by Ms. Shar. Hearing no objections. Okay, motion passes. And I think we hit the other agenda items already. So if there are any announcements from anyone today. I do have one announcement, and that is, I know we announced in the last meeting that along with Senator Tello Titagui, we introduced bill number 259-36, which is a companion legislation to this task force to help us begin finding some resources, some money to pay for any of these facilities that we may plan for in the future. And so that bill will be publicly heard on Monday, May 2nd at 9:00 a.m. So I'd like to invite the task force, if you'd like to be there at the public hearing, or any stakeholder that you may know, to please share that information. All right, okay, and I don't have a proposed date yet for our next meeting, but I will be sure to send a notice to everyone, and of course, send out our open government notice. So any other announcements? No? Okay, thank you so much for your time, everyone. Thank you, Senator Ada, for joining us, and to all of our task force members and those viewing at home, Siduos Maasi, for following along. The time now is 11:24 a.m. and this meeting is adjourned. Be safe, everyone, and take care. Happy Easter to all of you.